first step for a biliopancreatic endoscopist, but probably is still the more challenging, procedure, although it's the first step and for all the biliopancreatic endoscopy. So the chair is yours. So thank you.
Thank you. The historic part of the interventional endoscopy, the ERCP. Thank you for this very nice and kind introduction. And just in few words, wanted to have a special thanks to USG and today to Fujifilm to always their support for the education and the training in our field of the therapeutic endoscopy. So my first question was when I tried to prepare this lecture was why URCP is always so mysterious finally, because sometimes it seems to be so simple and sometimes it seems to be so complex, so difficult. And one of my master tell me a day, Geoffroy, the URCP, it is 3 minutes or 3 hours. And it is sometimes like this. And I think that the first response is that there are as many papilla as there are several faces on the earth, and all these different aspects of papilla explain that the orientation inside the common bile duct could be different, difficult, or very simple and direct when you perform URCP. And finally, if we have just a few introduction on the different factors that could explain these difficulties, you have to remember always when you perform URCP, the anatomy of the papilla and the common bile duct and the propancreatic duct, just to understand where you have to go, and the movement should be from the lower right quarter to the upper left at 11 o'clock. And for this, you have to use the bending capability of the papillotome. And you are always to remember when you have to cut to perform the sphincterotomy, all the different work which have been published on the vascularization of the papilla, and always remember that the green zone, the green area, is between 11 to 12 o'clock because it is the place where the vessels are the less number in this part of our anatomy. Just a small slide to remember you the 4 basis technique to perform papillotomy, from the sphincterotomy, which is the first line technique using a papillotome with a guide wire most of the time, to the free hands needle knife papillotomy, the fistulotomy, one fistulotomy, and we will decide depending on the aspect of the infundibulum, but we will discuss that after. And the last technique, which is certainly the most dangerous one, it is a transpancreatic sphincterotomy. And I tried to summarize before the video cases the last guideline, which are always good one, I think, at this time. And you know that after a failure of 5 attempts during 5 minutes, it depends, and you have to change your technique depending on the selective pancreatic duct cannulation. And if there is one, you have certainly to try to use the double guide wire technique. And if not, maybe the free hands technique or the suprapapillary fistulotomy. So let me show you a first video. It was a patient with stone, and I want to leave you the video without any wide break or cut, because it's just to understand that sometimes the real life is for everyone. So here I use the AX tome from MedWork to perform this procedure, which is very nice due to the very thin tip of the sphincterotome. And I start like I start usually. It means that I try to have a good orientation at 11 o'clock with the sphincterotome using the binding capability of the papillotome. And you can see that it was difficult, and it was first a failure. even we try to use the tip of the guide wire, and it could be an alternative to introduce your material inside the common duct. You can use the only tip of the hydrophilic guide wire, try to find the good orientation and the bile duct. So you can see that sometimes it is not so easy. You try to search, you wait the famous number of 5 attempts before to change the technique you want to use. And I just speed a lot then to show you that after that, the second step is to perform a little opacification, try to have an opacification, a duct opacification. And if it is not possible, you will change your technique for an alternative technique. It could be the freehand technique or the fistulotomy. Here you will see that during the second opacification we will perform, we obtain the pancreatic duct. And in this condition, the second step is to introduce our guide wire in the pancreatic duct without any most important opacification to avoid the risk of acute pancreatitis. And when you introduce your guide wire, here it was the GPS wire from Medwork, when you introduce the guide wire inside the pancreatic duct, you can perform the double wire technique. So I just accelerate the video, the movie, to show you that now I have introduced the guide wire inside the pancreatic duct, and I will perform the famous double guide wire technique. And I think that the secret to succeed with this technique, it is to bend a lot the papillotum, because the first guide wire inside the pancreatic duct allow you to be more precise and to open the bile duct, but in the same time, it is possible to be parallel to the first guide wire, and you go always inside the pancreatic duct. If it is the case like this, when I try to perform the first attempt, you have to stop and then to have a more important elevation with the elevator, bedding of the papillotum to found the famous 11 o'clock orientation to be inside the common bile duct. So I just left the end of the video just to show you that I changed my position. I tried to bend a lot the papillotum and just to have this better orientation like this. And when you do this movement, and sometimes you have just to pull a little the duodenoscope to introduce the tip of the papillotum inside the common bile duct, you can see that directly you go in the common bile duct. And then you can finish your procedure, do the opacification, and extract the stone. And we will, of course, insert a pancreatic duct to reduce the risk of acute pancreatitis. Here, it was a second case. It was a stricture of the common bile duct due to pancreatic tumor, cephalic pancreatic tumor. And I show you the different way to perform the freehand technique after failure to accede to the common bile duct. And here it is the orientation and the right position to perform the fistulotomy, just up to the papilla inside the common bile duct sphincter, the bile part of the sphincter of the papilla of the ampoule. And like this, you will start, and I prefer to start when there is a bulging effect of the infundibulum. It is a type 2 or type 3 of anatomical classification. I try to use the fistulotomy because we know that with this technique, you reduce the risk significantly of acute pancreatitis because you are not in contact with the pancreatic duct. And me, I prefer to be very step by step. I want just to cut the mucosal layer, then to expose the sphincter, and then if I need to put another impact of coagulation to introduce my guide wire inside the sphincter. So, and I think it is a good way, because if you do a large cut during the first impact, the risk is to induce a large and huge bleeding. And when there is a bleeding in this situation, it is impossible to introduce your guide wire. So always, even if you can do that with the needle, because the needle are sometimes associated with 3 different lumens with a guide wire, which could be introduced using the needle knife. I always prefer to use again a sphincterotome. It was the same sphincterotome as the XS tome, because with the tip of the guide wire and with the beading capability, I could be more precisely placed to introduce the guide wire. You can see that it was not possible because the hole we performed inside the sphincter was not too large. As required in this situation. And this is the reason because why I tried to perform another impact. And here you can see that we have a good access for the command button with some bile which is now visible, and just have to introduce the tip of your guide wire and to finish your procedure, as you can see with the fluoroscopy. So it is finally easy if you are very step-by-step management of this procedure, and if you always respect the different steps like this, I think. But avoid always the bleeding, which could be very difficult for the rest of your endoscopy if it is the case. To finish, I always do a small papillotomy before to do other maneuver, just to be sure that the access is correct to the command by that. So, Cecilia, that's all for me. I hope that it will be interesting, especially it was the basis. It is the basis, but it was the topic of the lecture, and I hope that it will give some tips and tricks for our colleagues.
So Geoffroy, thank you very much. It was really interesting, and I believe for most of us very didactical. So I have one question for you. You show us so many pictures of different papilla. So probably we never face with the same aspects of the papilla. Although, as we know from 2019, there's a main classification of the major papilla, the Scandinavian one, which is probably the most used. That is that classify the papilla and estimate the risk of difficulties in bile duct cannulation. And so do you usually use this classification in your routine practice? And if yes, how this affect your management of the procedure? You go step forward even before the 5 attempt to an alternative technique or not? So which suggestions?
Yes, it is very interesting because when I have a look on the different reports from my colleagues and my friends, I have to confess that this classification is less and less used in France. I don't know if in other countries, but and it is not a good point, because finally we know that in high score of the classification, finally, if there is a bulging effect of the papilla for the infundibulum, we know that the fistulotomy present a higher technical success rate, and it is, I think, important to switch to fistulotomy in this situation. And on the other hand, on the other side, when you have small papilla, small, soft and small papilla, the class 0 or 1 of this classification, we know that you have to switch or to use a double guide wire if you have an access, a pancreatic access, during your first cannulation, you have to use it and to perform a double guide wire, I think, because there is a higher risk of technical difficulty, as you mentioned previously, and maybe you have to accept that you have to switch rapidly to access to the common bile duct more easily, finally, easier, like when you respect this different step. Finally, I think, and it is a good point you said, finally, I think that you have to accept that ERCP is sometimes difficult, and if it is after 2 or 3 attempts difficult, you have the feeling that the anatomy is maybe different in this patient. Try to switch to an alternative technique. Because the acute pancreatitis after ERCP is mainly due to the lot number of access of attempt and of different insertion of the guide wire you will try to do with the same technique. So try to switch, to change your attitude, just to have some question and response. Sometimes it is good to have your fellow at your side just to discuss. It is very good.
Yeah, it is.
And to change your habit and your attitude. Yes.
Yeah, I really appreciate for your lecture and for your answer that ERCP is a mix of stop, think, but move rapidly to alternatives. So this, I believe, is probably what really makes working a team and in ERCP, because there's always a matter of stop thinking, but you have to move rapidly to another another technique if the first fail. So we have a question for you, and then we move to the second presentation after. If there are any other question, we will try to answer at the end. There's a question that asks, when you go for the second time into the pancreas, and you keep trying to cannulate the bile duct, or you do the transpancreatic sphincterotomy and avoid the repetitive attempts?
If you go inside the pancreatic duct with your second guide wire, it means that you don't have any binding effect and bad orientation with your papillotomy. So you have to change and to do a lot of elevation and binding effect with the papillotomy to change the orientation to be more at 11 o'clock. And it will be a success, I am sure. The transpancreatic sphincterotomy, clearly, it is the end of the end for me. It is a technique I will use in the last situation, because we know that it is a higher risk of post-ERCP pancreatitis. And it works. It is not so difficult finally, but the risk of acute pancreatitis after that is higher reported in the literature. So you keep it for the last technique if you are in failure situation.
So I just make a provocative question. So when you cannulate the pancreatic duct, you have bile duct stone without cholangitis, you cannot cannulate the common bile duct, you reserve a second attempt of the ERCP, or you move to the transpancreatic sphincterotomy?
it depends from the anatomy of the infundibulum as we discussed with the classification. If I have a bulging with a large infundibulum, I perform a transpancreatic sphincterotomy because technically it is easy. If you have a small papilla, I don't perform a transpancreatic sphincterotomy. I come back.
Okay.
Clearly.
So thank you, Geoffroy. We will see if at the end of the meeting for the final discussions. So it is